Excellent. And let's get started. Let me just remind you that there will be an opportunity to ask our speaker questions at the end of the talk. So at that point, please do feel free to submit your questions then through the chat function, and we will have our question session in that way after I've collated the submitted questions. With that, I am absolutely delighted to introduce to you our speaker. Dr. Karen Thomas is a clinical academic chartered physiotherapist specializing in stroke care and neurological rehabilitation. She is a HEE ICA post-doctoral clinical academic fellow at the University of Cambridge School of Clinical Medicine and a research associate there. And she's also a senior physiotherapist at the Eaglewood Neurological Center at the Addenbrookes College Hospital. She completed her PhD in 2020 at our very own Lucy Cavendish College, and her thesis was titled Understanding Post-Stroke Fatigue. She has presented at several national and international conferences, and she has garnered several awards for her top scoring abstract submissions. Her research interests are post-stroke fatigue, self-management of neurological populations, and the impact of allied healthcare professionals within the UK National Health Service. She also spends a lot of time advocating clinical academic careers for young AHPs and on the water in whatever boat she can get her hands on. And with that, over to you, Dr. Thomas.
Brilliant, thank you very much, and thank you for inviting me to talk today. I was just saying before the talk, this used to be a talk in person before our formal dinners at college, which I always enjoyed going to, and there have been some brilliant speakers both through the Live at Lucy series and in person before that, so I feel very lucky to have been asked. So today I'm going to be speaking a little bit about my own research and also expanding and thinking about neurological conditions more generally, and then having a think about what we can do, all of us, to help those who suffer with fatigue. That may be as someone who suffers from fatigue themselves, it may be as a supporter, it may be as a healthcare professional, or even thinking on a wider systems level as well at the end. So let's see if this works. There we go. Right, so as I believe we have quite a few people here this evening, it would be great to find out a little bit more about you. So I think these links have been popped in the chat. If you could just follow them and let me know, that would be brilliant. I'll give you a few minutes. Great, so it looks like we have a mix of healthcare professionals or clinicians, and also quite a few people who are just interested in knowing a little bit more, which is great. And we have no experts, so I'm told. But most people who have a little bit of understanding but would like to know a bit more. Brilliant. So just to give a little bit of an overview on what we're going to cover today. Firstly, I'll give a little bit of a background on the topic and why I research it, why I'm passionate about it, and why I want you to know a bit more. And then the way I'm going to structure it is firstly focusing on the individual. That could be an individual with a neurological condition, and also their supporters, and then think about healthcare professionals, and then bring that together and talk about kind of wider level changes. So the reason why I'm going to take this approach stems from this model from my PhD, which myself and Donna Malley created in the first year. And we felt that we would be able to get a more unique and a broader insight into fatigue if we looked at all of these areas together. So thinking about the differences and the similarities between how stroke survivors or individuals with a neurological condition, their supporters and clinicians, as well as, of course, the literature that's out there, how all of those individuals look at fatigue, both from the acute end of the spectrum in hospital through to the community. Okay, so we could cover this in great detail, but I'm going to just kind of make the most important points here. So fatigue in neurological conditions is extremely common. There are lots of different conditions I could cover, but I'm going to focus mostly on stroke, multiple sclerosis, and Parkinson's today. In all of those groups, again, the literature varies because we don't have a set in stone definition, so it's very hard to work out exactly how many people experience fatigue, but it's roughly, looking at all of the figures, between 33% and about 85% across these conditions. And it's very common in multiple sclerosis and stroke. So why do we need to look at this in greater detail? The impact of fatigue on those with neurological conditions is extremely high. It affects quality of life, it affects return to work, it affects mortality, risk, and rate. There's quite a limited understanding of why individuals experience fatigue, and of course, as you'd expect, it does vary condition to condition. But that applies for everybody. There's theoretical modelling and understanding, but most of the research that's been done on pathophysiology is based off theory and hypotheses that haven't been tested, as opposed to set in stone facts. This is also the case for management. As you can imagine, if we don't have a set definition, we don't have clear assessment, it makes managing fatigue very, very challenging. There are also a lot of associated factors, and we'll come to this again and again as we look at what the literature is saying across these conditions. The main ones, though, that come up across neurological conditions are depression, pain, sleep hygiene, and actually anxiety as well. Okay, so as I said, we don't have a set definition, but even though this is very long-winded, I actually quite like this one because I think it just shows how much of a multi-dimensional construct fatigue is. As you can see, it's physiological, it's psychological, there are primary and secondary elements to it, and we can have central and peripheral fatigue. But the main distinguishing factor of fatigue in neurological conditions is that the fatigue rarely responds to having a nap or having a sleep, which I guess you or I would do if we'd had a really long day at work and felt tired. So that's the big difference. So we're going to firstly have a look at the individual level, as I said. So this is thinking about the individual who is suffering from the fatigue and their supporter or the people who are around them in day-to-day life. So thinking about fatigue across the conditions, these are the three main areas which I found kind of aligned. So quality of life is consistently affected. So on quality of life assessments scales, we find for, at least in the three which I'm looking at in more detail, which are multiple sclerosis, Parkinson's and stroke, there are reduced scores. This could be because of the unpredictable nature of the fatigue. You can't always tell when it's going to come on. That can get better the longer you're experiencing the fatigue and the more support you have, but quite often, from what I've been told and what I have read, it may hit you when you're not expecting. We also found that it affected health-related quality of life scores more than any other part of the index, which is interesting. And then there's also a big impact on individuals' mental well-being. I'm going to cover this in greater depth looking back at my PhD studies in a moment, but quite often individuals with fatigue feel quite isolated and struggle to explain what they're experiencing to others around them. And I also was told by individuals in my interview study that they didn't feel like they could go to their GP because, you know, other people who've had a stroke, you know, they can't walk. All I am is tired. But then you ask them when they last left the house, and it could have been several months. And the reason, when we got back to it, was because of the fatigue. It also results often in low mood, and a lot of the literature shows that for these three conditions, when fatigue was, when researchers begun to look at fatigue, quite often depression and fatigue were seen as one and the same. They were seen as the same thing, and they came together. It's only been more recent in the last few decades that it's become clear that the two are actually separate. But still, low mood is a big aspect of the fatigue, and also fatigue often comes with depression. And then also going back to what I was saying, that it's unclear, one, on how and why fatigue is occurring. It's also not clear if there's a timeline. So generally, it seems that fatigue does get better over time, but it's not in a set time frame that we've got literature to support. So often the individual is feeling extremely fatigued, quite isolated, and they don't really know where the end is. And then also there's quite a lot of loss that's associated with this. They feel like they don't have as much control over the fatigue, over the condition, and over their life and the things which they potentially were doing before. Loss of time, and also loss of role. And again, I looked into this in a little bit more detail in my interview study for my PhD, so I'll cover that as we come to it. Okay, so I just wanted to quickly show this study, which I think is really good. So Eilertson carried out a study. This was specifically on stroke, but actually a lot of the characteristics you can see here are relevant, again, from my understanding, to other conditions. I'm sure those of you who are here who suffer with neurological condition can either agree or disagree when we have our discussion. So some of the key areas here are energy. The individuals tend to have a lack of energy. There's an unpredictability, and it's quite complex. And we also there at the bottom come back to this lack of definition and the difficulties associated with that. And then something which I found as well is that individuals tend to cope or not do as well, depending on how they adjust to having the fatigue and to it potentially not improving when there's an expectation of it improving. So they may take it into account and adjust their lifestyle, and then there's others who struggle and they're trying to fight the fatigue or win it over, or, you know, keep pushing on through. And then there in the middle as well, we can see acknowledgement from others is really important. And again, I'll come to that. So going on to one of my first studies I did in my PhD, I thought these studies were really interesting, but actually all of the research that had been done so far, you had either researcher or clinician bias of some kind. So I decided to have a look at the Talk Stroke Forum, which it isn't online anymore. There's now a big hub, but it used to be the largest forum for stroke survivors, and lots of supporters and caregivers used it as well, which was a really nice way of getting naturalistic data, which essentially means what I said before, it's free from bias. So when I was looking at search terms, I first put in fatigue and got very few results come up. And I found that actually the word tiredness was used a lot more by users. And this online forum as well, it provided a really nice, rich source of data from which the subjective experiences of the issues could be collected. And especially in the era we're in currently, online forums, online communities, Facebook groups are all being used more by individuals with long-term and neurological conditions. So what did I find? I will bring up the key themes. And actually, we found that these link together quite nicely. So the acceptance of the fatigue was linked to the belief that it was a direct result of the stroke. So it's described as a legacy of the stroke that they were now stuck with. And this also ties into the medicalisation aspect there at the top. The medicalisation of the fatigue then exacerbated the perception that clinicians were unable to help, or at least were perceived to be inconsistent in the advice which was being offered. And then I guess a few other key points I want to make here. Interestingly, the term or the phrase "a legacy of stroke," from speaking to healthcare professionals and clinicians about this, it wasn't something that clinicians were saying to others, but it was used a lot on the forum. So that shows that potentially individuals were coming to this forum looking for advice and thinking, oh, actually, yeah, that kind of sums up what I'm thinking, and then took that forward, and then someone else took it. We also had a look at the explanations that were being given, because I really wanted to see how it varied, you know, an individual who has this neurological condition compared to a clinician who might be treating it. And the most common term that was used was, my brain needs to heal, my brain needs time to heal. So something quite simple, but it was something that connected with the individuals on the forum. And again, we had the group, similar to the previous study, Eilertson study, we had the group who were trying to fight the fatigue, and the supporters who were encouraging the individual they were with to just keep on going. And then we had a much bigger group, which was good, who were accepting the fatigue and saying this is normal, and that was how they were supporting others. They were saying this is normal, this is to be expected, don't worry. So some of the implications from that are that really a clearer framework of post-stroke fatigue, or potentially fatigue and neurological conditions more widely, would be really useful for clinicians, focusing on the stroke survivor perspective, the terminology they were using, the explanations they were given. And then this also, if research like this was more accessible for those who are supporting stroke survivors, in particular here, it could improve the patient-practitioner relationships. As we touched upon, quite a few individuals from the forum felt like they weren't being given the support which they needed. And also it might standardise understanding a little bit more. So then I wanted to know a bit more, because forums are great to have a look at, but you can't ask words questions. So I needed to get some people. So my next big study I did was some interviews, and I interviewed 24 stroke survivors in the community, and I gave them the option to bring a supporter with them. And actually, as you can see, 19 supporters were involved in the study. So a lot of the individuals who wanted to be involved also wanted either a sibling or a significant other there with them. And then I thematically analysed the results employing a symbolic interactionist perspective, and I'll touch upon that a little bit more as we come to the results. So I just wanted to give a few examples, some quotes of how individuals were describing the fatigue. You can see, I think the main one for me is on the bottom left there, saying it's just a feeling of like that was how they described it. But that happened a lot, and the use of metaphor as well. And then also how fatigue makes stroke survivors feel. I think quite often and I mean, I'm a culprit of this myself as a healthcare professional, when you're busy and you're trying to give a good kind of clinical reasoning and plan, it's sometimes easy to forget this side of fatigue. And again, from looking at the literature, this is similar for Parkinson's and multiple sclerosis as well. And you can see there's a low mood, there's a thinking, well, what's the point in carrying on? And another quote I've got here is, they said, it always makes me upset when I talk about it, because everybody has their life mapped out, how they want it to go. Then what happens? It takes it all away and you have to start again. And then the fatigue keeps stopping you again and again and again. I think that summarised it quite well as well. So having a look at the results of the interview study. So when a person's role in society is lost, one of the key areas of the sociological approach I took is thinking about self-concept and identity. And we were finding that their identity as a result of the fatigue, as a result of the stroke, was changing and narrowing. There was a lot of reference to the word normal, and a lot of people finding adjusting and accepting the change and not going back to where they were before really difficult. Also, a lot of pronouns were used, like us and we, and which showed the importance of having the support network. And everybody, even those who lived by themselves, said, you know, they had a neighbour who came and helped them, or you know, there was someone down the road who'd had a stroke, and it was really useful to be able to go and chat to them. So yeah, a big part of the interviews were that the stroke survivors and their supporters didn't feel like clinicians were always acknowledging and recognising their individual lived experience. Which takes us to individualising the care, kind of saying everybody is different and everybody needs to have a different management strategy. There was one individual who said to me, my goal is that I want to get a dog, and I'm going to make sure that I can do everything I need to be able to get that dog. And a really big element of that for him was managing his fatigue, because he had to be able to take the dog for a walk. And for him, he had that goal. He hadn't quite got the dog yet, but that was what was motivating him to make the changes. And then also the need for adaptable strategies. So, for example, an individual with severe aphasia might not want to go to a group session, or might not want to go to a face-to-face clinician appointment. They might find it more useful, and their supporter, to have some clear information, which then they could refer back to. And then also the ability to contact individuals for support. So quite often they felt that once they were discharged from hospital, that was it, and they couldn't get back to that group of people who would help them there. And then also just wanted to make the point that the accounts and the experiences of the fatigue itself hugely varied in the 24 interviews I did. And then lastly, information and how it was given was seen as really important. So for example, lots and lots of people were saying at the point of discharge, they were given loads and loads of information, but then they never used it. So it needs to be at the right time for them, and it needed to be tailored. So what are the implications of this? So first one, communication. The communication needs to be inclusive of their supporters. It needs to come at the appropriate time, and it needs to not be a one-off occurrence. There was a perceived under-recognition of fatigue. So they wanted for stroke survivors to feel included and recognised, and the focus needed to be on the lived experience across the pathway. And also we had a discussion about the clinician not really ever starting the conversation. So it felt like it was always on the individual experiencing the fatigue. And when they felt like it wasn't an important issue, they just didn't have the conversation. And then having a look, I had a look at some literature for cancer, slightly different, but actually in their guidance for assessment of fatigue, they advise nurses to just ask about tiredness and ask about fatigue at regular intervals. So they're just starting that discussion if it needs to be there. And then again, as I said, individualising care, really, really important. So then moving on to the healthcare professional side of things, this is again, a little bit off track, but I really like this infographic because it kind of shows that the effect a healthcare professional can have is huge. And if we say the right things and, you know, do the right thing, then we can make a really big impact. We see so many people. So evidence-based practice, quite often we as clinicians, we also use our experience and our experienced colleagues, but we're also looking to find out what the evidence is telling us. And as you can imagine, with the lack of definition, pathophysiology, information and assessment scales, very difficult for clinical guidance to help. And you can see here, Parkinson's, the latest Parkinson's NICE guidelines did not include fatigue at all. The only area where it was included was within the depression guidance. And then for multiple sclerosis, there was actually quite a big section, and we'll come to that in a moment. And then for stroke, there were some recommendations, but they were mostly around supporting the individual without a real clear way to do that, and assessing for other factors that might affect the fatigue. So then this is the guidance for multiple sclerosis, and you can see here that again at the top they've suggested assessing for these other factors that may influence fatigue. Also an MS specific one, which is that the fatigue might be affected by heat and overexertion. That's not so much the case for stroke and Parkinson's. And then also a variety of pharmacological and non-pharmacological options there. So I wanted to find out what was happening in stroke, as I couldn't really find any research to say what was happening on the ground in clinical practice. So I did an online survey, which some of you might have responded to several years ago now, and we had a fairly good response rate. Over 100 people took part in it, and we also had a mix from acute all the way to community settings, which was really useful. So the first question I asked was, what does post-stroke fatigue mean? What is post-stroke fatigue to you? And the overarching theme that came out here was that it does need to be treated as a serious medical condition, which is great. And it's because of these reasons that it's important. It's a medical condition, and it's extremely debilitating. However, we found that the definitions that were given and the approaches that came out varied a lot, and this may have been, you know, between two occupational therapists who had the same amount of experience in the same field. One might be calling it tiredness, one might be calling it fatigue. That's not so much of an issue if it's explained well, but then things like one would be saying it will improve within 1 year, or it'll improve in a specific time scale, whereas another might be saying it probably won't ever improve. And then also the role of rest. Some were saying all you need to do is rest, and others were saying rest will not help. So you can see there were differences there between individuals in the same profession and the same level of experience. And these are just a few quotes that summarize those areas. So there you can see at the bottom, improves 1 year to 2 years post-stroke, and another said it's ongoing. You can also see at the top on the right, this is one of the definitions, or one of the answers which I was given, and you can see how much that varies from, say, the individual who said to me, oh, it's just a feeling of ugh, and that's how they described it. Hugely different. And this was a personal favourite. Again, as you can see, they've taken a very medical and clinical approach to this. So if someone with Parkinson's, multiple sclerosis or stroke was told that, do we think they would take that in, or they would understand it? Possibly, but also quite possibly not. So what can we take from that? So there was a huge lack of standardization and differentiation in the clinical approach that was taken. There was also variation implicitly and explicitly that could lead to conflicting messages for the individual. In terms of recognition, the confidence healthcare professionals had in discussing fatigue and in managing fatigue and explaining it varied a lot. Some people said, I don't have the knowledge or the understanding, and so I don't cover it, and I need to. And then also it was recognised by healthcare professionals as a legitimate aspect of the condition, again, which is great. And then in terms of individualising the care, the importance of patient-centred assessment was highlighted, as well as ensuring that the stroke survivor and the supporters understood their own fatigue patterns, again, which is really good. So then moving on to management. So we'll have a look first here at across the three conditions, Parkinson's, multiple sclerosis and stroke. And these were the areas which we found across all. So in each, different pharmacological interventions had been tried. The actual intervention did vary. None, apart from multiple sclerosis, had been proven to have a positive effect. And in multiple sclerosis, it suggested that it's part of a multifactorial approach. And then we also had the behaviour change interventions, and this was specifically for those who'd been suffering from fatigue for longer and it was more chronic. And then also another area which I found across was the discussion of energy and trying to explain to the individual their fatigue in terms of the energy. So what can you do? Do you have enough energy for this task? Okay, that probably means you're not going to be able to do this one then, and then thinking of it in that way. And then also exercise and activity interventions. Again, the evidence varies on this, but it has been found that some physical activity and exercise is good in fatigue, according to the evidence. And this was in multiple sclerosis and stroke research specifically. So then, again, coming back to my research to kind of bring this together, at the end of my interviews and my therapist survey, I did a focus group with healthcare professionals. So the reason to do this was to try and understand in a little bit more detail how post-stroke fatigue was assessed and managed. And then I also showed all of the individuals who came to the two groups what I had learned from the individuals, so from the stroke survivors and from the supporters, to then kind of come up with some ideas and a way forward. So some of the things that came up on how it was currently managed, which it fitted in with what came up in the therapist survey, were having a multi-factored assessment. So here, the second one down on the right, they were kind of saying that you need to help them understand and work out where their hotspots are, if it accumulates and so on. And then also thinking about how to educate them about their own fatigue patterns, and that there was discussion around use of the Stroke Association leaflet, and there's also a really good multiple sclerosis advice page or hub through their charity website, which is great. And then also the value of face-to-face and coming back at regular intervals to assess and learn and improve. And then also there was an understanding that really what you needed to get to was a way to help the individual self-manage, because as clinicians and healthcare professionals, we can only be there a fraction of the time. And they also touched upon the difficulties, for example, of an acute physiotherapist who had worked with someone in hospital, then passing on good information to someone who is either in the early service discharge team or even later the community team. And the community team felt like not enough was being done at the start of the pathway. So that was interesting. So how did they think that management could be improved? So firstly, there was discussion over kind of baseline resources. So this touches upon what I found throughout all of the healthcare professional studies, which was that a lot of healthcare professionals didn't feel confident in their own skill level, and so didn't broach the topic with the individuals and with their supporters. So they needed more education and better understanding. And then there needs to be handover across the care pathway. And actually, in one of the focus groups, because everyone was in the room who needed to be, they decided to make that change there and then, which was great. It just needed to be a change of a document that was on the shared drive and then used across the pathway. So very simple to do. And then lastly, even though the value of lived experience was covered, once I showed them the results of the forum study and the interviews, they were saying, oh, actually, I think we do need to do more. So to kind of bring all of that together, fatigue is extremely common, and it's often seen as a debilitating and unmet need. So we need to all take it seriously and contribute to an increased understanding. That's supporters, so the individual feels supported day to day, and healthcare professionals. And then also in terms of academia, we need more literature, more high-level work done, so that can inform guidelines. Presentation of fatigue is variable. One size doesn't tend to fit all in terms of management, and that's what the guidance and the evidence that is out there is saying. And then also going right back to the first study, that concept of fighting or accepting the fatigue. Do they fully understand and acknowledge their fatigue? And then understanding is variable, and this is both the individual with the fatigue, the supporters, and the healthcare professionals who are trying to help manage it. So how can we improve that? And then I guess the last point is that keeping up to date with the literature in a field that is as young as this is really important. But as I said, high quality evidence needs to be there before it can be adapted and taken into clinical practice. So I've just got a few recommendations which I think we could consider to improve how, on a wider systems level, we could improve fatigue management and care. So I think it needs to be more visible, and this means that if possible, then fatigue needs to be raised in all settings. That could be the GP when they're first reviewing them after their stroke, or after a flare-up in their multiple sclerosis, or a check-in for a Parkinson's patient. So if the discussion is happening like it is in cancer a little bit more, then it will be seen as more of a recognised and legitimate condition. And then also accessible resources could be really useful. So I was looking at one point creating a very simple infographic that just had prompts on for the clinician, and also included some of those terms and words that we use, such as it's just my brain healing, instead of you saying, oh, it's because of your neurotransmitters and because your brain's this. And then also reminding individuals as their supporter, as another individual with a condition, and as a healthcare professional, that fatigue in neurological conditions is extremely common. And now, actually, I'm not sure I like the word normal, because I think that does take you back to what used to be normal. But just to reassure, I think reassurance is really important. And then also, at least for stroke, the Stroke Association leaflet is great, but it doesn't actually incorporate any stroke survivor or supporter accounts in the resources. So it would be great if that could happen a little bit more. I'm not sure if that's the case for MS and Parkinson's or not. And then also, I think we could have improved continuity of care across the pathway. And this can be done very simply. As I said before, that this happened within one of our focus groups. We can share resources. Quite often, community therapists look at this and deal with this a little bit more. So maybe they can help inform their colleagues at other parts of the pathway. And then including fatigue in handover paperwork. So it's something that has to be thought about. Another area which I found through discussing with colleagues is for GPs, they don't have a code for post-stroke fatigue. So one individual who I work with was going to have a look back to see how much the conversation was happening, and he couldn't because there wasn't a code for it. And then also offering contact details to families at the point of discharge, or at least signposting to resources. It might not mean that they speak to exactly the same person if it is going from acute to ESD to community, but it means they won't feel like they've just been dropped out of the system. And then I know I've banged on and on about this, but incorporating lived experiences into the resources would be really valuable. Quite often, again, just from my experience, the individuals who I spoke to and I've worked with feel like they're the only one. They're the only one who experiences the fatigue on the level they do, but actually there are lots of people, and possibly clinicians being able to signpost to an online hub or a video or a group session could be really useful. And then also within this, thinking about the terminology, so reducing the compartmentalized and medicalized terminology in initial explanation, and more choosing metaphors and taking the question back to the individual. How is it making you feel? And then lastly, including supporters as much as possible. Again, this is another one that's tricky, but really, really important. And then that means that they, in the initial period after hospital, if they've been in hospital, they feel like they're able to support the individual. And then the kind of the very last one is these standardised resources. So patient and supporter perspectives are really useful to characterise fatigue, and more work is required to transform this understanding of the subjective experience and experience-based management into an appropriate format that can be used in clinical settings. So further research might provide an explanatory framework for healthcare practitioners to better inform patients and supporters about the nature of their fatigue, as well as exploring interventions that would be valued by the individual to assist in managing this long-term and debilitating symptom of neurological conditions. So I'd like to just thank a few of the people and the organisations that have helped me carry out my research. These 3 NHS trusts have been involved in almost all of those studies, which has been highly useful. And then just a few of the people who, again, have helped me out. The top 2 are medical students who gave up lots of their time voluntarily to help me out and come to conferences with me. And then Donna Malley and Anna Desimoni have been brilliant mentors. And then I have my supervisor team as well. So I just wanted to thank them and thank the college again for letting me do this talk. So hopefully now we can open up for any questions or any thoughts. It would be nice to have a little bit of a discussion. So if anyone, I know we've got a few individuals here who have neurological conditions or are supporters, it would be really nice to find out your thoughts on this and if you identified with any of it.
Thank you very much. That was a really great talk. As you say, we don't have too much time, but let's open up the floor for questions. And I'm going to collate some of them. There's lots of comments in there, so also feel free to take a look at those. However, I shall start with some of the questions in the chat function. So Jane asks, this was the first question that popped up. How long does the fatigue last following a major stroke? Is it best recovery within about 2 years?
So it's very hard to say. It depends on lots and lots of factors. So for example, the fatigue levels which the individual had before the stroke, the area of the stroke, and also it varies person to person and what they're kind of getting back to, what their baseline is. So hard to say, but research has shown that over time it does improve. There aren't too many studies that have been done over more than a few years, so difficult to say for certain. Yeah.
Great. The next question is from Humaira. My apologies. Can it affect babies and their development if they find it difficult to sleep? And can fatigue and neurological conditions have a genetic tendency?
So it depends on the neurological condition, I guess. I would say though that this type of fatigue is different to general fatigue and just general pathological fatigue as well. But so if a baby did have a condition that what was causing them to be fatigued, I think it would have an effect on their development. But this is me speaking from a clinical background, as I used to work in paediatrics. So literature wise, I hold up my hands. That's something I need to go away and have a look at. But it sounds like an interesting question to look into, definitely.
Excellent. The next one is from Keith Thompson, and they want to know if there are any major differences between the fatigue in stroke victims and those with multiple sclerosis.
So the main differences really are, which kind of came up in the guidance, if I can find it. Oh, too many animations. Here we go. Are that here 1.5.3 specific to MS, and it's similar to just MS in general, that it tends to be exacerbated by heat changes, overexertion and time of day as well. So I would say those are the main differences, but equally post-stroke fatigue can affect individuals completely differently as well. So it's more thinking about the individual as opposed to the condition, I would say. There are clear similarities between these neurological conditions, and the only big one I would say that's different would be the heat.
Interesting. So the next question again is from Jane, and she wants to know if anyone's heard about hyperbaric oxygen treatment that she's tried previously with her son.
That sounds interesting. I mean, I think I saw a small trial have been done in the latest post-stroke fatigue management kind of meta review that was done, but it wasn't a high enough quality study to be able to take any clear results from it. But I guess if there's anyone listening who has used it, feel free to put in the chat and Jane can reach out to you.
Absolutely. Humaira wants to know if fatigue and neurological conditions can affect normal brain structure and the rate of impulses.
Not that much research has been done on this. I think it should be. It would definitely be interesting. There has been, I think, one of the big focuses on energy has been around that it. So a researcher in London, Anna Kupaswamy, she has found that reaction rate is reduced in individuals who have fatigue, and that was specifically post-stroke she looked at first, but she's actually expanding her research now to more neurological fatigue and fatigue generally, because she thinks there are links across conditions with that. So yeah, have a look at her work. If you Google her, I'm sure she'll come up.
Excellent. A question from Haz is, are there any ideas for good resources to give patients regarding fatigue?
So the easiest one to get is the Stroke Association leaflet, and it is a good leaflet. It does give you lots of information, but as I said, I don't think it's perfect because it doesn't have any actual accounts of stroke survivors. There are some videos on YouTube if you put in post-stroke fatigue, and also I would be a big advocate of going on Twitter, because a lot of stroke survivors and just individuals with neurological conditions are on there, and I've noticed that those followers of mine have been really good at signposting and sharing resources which they found and their own experiences. I'll just go back to my that's just my Twitter there if anyone wanted to follow me.
Oh, that's very useful to have. Thank you very much. Okay, and let's see. So let's move on to the next question from Humaira, who wants to know, could it be difficult to carry out normal unconscious breathing and heart rate if it takes too much energy?
Ooh, I'm not sure, but the research would point towards that being harder, and that would also, I think, would link to the difficulties individuals have with activities of daily living, going out when they exert themselves, and also there are links with anxiety. Which again, there are links between that and breathing, but I can't say I have seen much research done on that. Yeah.
Cool. Be very interesting to know for sure. The next question is from Jessica Blake, who wants to know, who do you think is best placed to provide service users with continuity of care? Because we would struggle to find the time to talk to patients post-discharge, but she's aware that this is an important part of their care that that should be worked towards.
Yeah, this is, I don't think this has a clear answer, because I think this relates to the postcode lottery. So actually, for example, where I did my interview studies around Thetford, Norfolk sort of area, quite a few of those who I went to see in their homes said, I would love to go to a stroke association group, for example, and meet people that way, but there are just none within a distance which they could get to. Again, in the interview study, quite probably about a quarter of the individuals I spoke to said that they were actually visited by a member of either Headway or Stroke Association. So I guess, and those individuals as well, they only said positive things about them, because I think they felt like they were a little bit more relatable than, for example, possibly their GP. I think GPs are too busy. So really the GP's role would be signposting onwards. But actually what came across to me, again, just my opinion and my perception, but it was just the idea that they had a phone number or they had an email address that they could contact if they needed to, more actually than someone coming to see them 2 weeks after, because sometimes after a stroke, that's too soon anyway. So it was more knowing that they could go back.
It's very good to know. And actually, she has a follow-up question along that in a similar vein. In order to give healthcare professionals a fatigue education baseline, are there any resources you would recommend that are used in training if the stroke guidelines are a bit vague?
So actually, I've been considering making the infographic which I mentioned public. So possibly if you follow me on Twitter, I'll post it on there after this talk, and that includes advice over explaining fatigue, advice over assessing it, and then management strategies which I used. And it's a big arrow tool. But other than that, there are, from the focus groups, the people who had the best education seem to be those who had someone within their team who had an interest in it and ran training, which obviously isn't that helpful. But other than that, I'm trying to remember the charities. It might have been Headway, or it might have been, I think it was Heart and Lung charity or association. I think people said that they'd been to training through them. So worth having a look, but actually it's a good question and I'll look into it myself. Yeah.
Cool, thank you. And our final question for the evening is from Jane Robinson, who wants to know what you think about pharmacological intervention for fatigue, such as modafinil. Modafinil? I hope I'm saying that right.
So modafinil is definitely the pharmacological intervention with the most promise, I guess, but equally it's been found, if you have a look at some of the more recent studies that have been done, a few big trials have been done on this, and they found that the side effects actually are kind of too large for it to be rolled out. So yeah, it's not safe enough for that reason. And then also I think my other point would be, as I've tried to make throughout the presentation, that one thing isn't going to fix fatigue. It has to be a multidisciplinary approach, both from the professionals and through the approaches that are taken. So it might help a little bit, but it would need to be in combination with other things, taking into account the side effects. So the GP is the person who can decide whether it's appropriate for the individual or not.
Excellent. Thank you very much, Karen. And I hope you will all join me in applauding her for an absolutely fantastic talk and a very interesting discussion session afterwards. And with that, today we shall be closing today's Live from Lucy. Please be sure to follow our events page on www.lucy.cam.ac.uk for more information on future Live from Lucy events, as well as our Alumni Festival 2021. Thank you very much for attending today's talk, and I hope to see you all soon.